and hear about periprosthetic fractures.
All right, Dr. Pat, let me know if you can see my screen here. All good?
Yes, we have your screen.
Okay, perfect. Well, for those of you that I haven't met, I'm Catherine. I'm one of the PGY4s, and I'm going to be talking about periprosthetic fractures around the knee. So the outline of our talk is going to be going through the incidence and classifications of these fractures, talking about the femur side, talking about the tibia side, and then briefly hitting on the patellas and the unis, and then some operative pearls. So, we've all seen these fractures come through the emergency department, but they're actually quite rare. The incidence is about 1.3 to 2.4%, depending on if you're talking about the femur side or the tibia side, and depending on the study you look at. This is expected to increase over time because the patients are living longer and we're doing more total knee procedures. It's associated with osteoporosis. 80% women, or 80% of the patients could be women. It's associated with increased age, low energy falls, and high BMI. It's also associated with some medical comorbidities such as steroid dependence or rheumatologic illness. There are some implant-specific errors that could be made in surgery that lend to periprosthetic fractures later on, and then some neurological disorders such as epilepsy, Parkinson's, and then myasthenia gravis, and then obviously post-polio syndrome and cerebral palsy. The question that we should all be asking when we see this is, number one, is the implant stable? And if it's yes, then we can talk about a variety of ORIF versus IM nail options. But if the answer is no, then we should be pivoting towards a revision total knee. The total gamut of treatments could be bracing and weight-bearing restrictions for non-operatively treated fractures, ORIF with or without an IM nail. Plate nail X-fix is kind of the total sum of those treatments. And then when we talk about revisions, we talk about revisions to stemmed components with or without augments, and then megaprosthesis. To have a conversation about these fractures, we have to know the classification systems. For the distal femur, the Lewis and Rohrbeck classification is one of the most commonly used. And type A refers to the non-displaced ones with the components intact. Usually you can consider non-operative treatment for these. Type B involves a displaced fracture with components intact. And type C involves a fracture, whether displaced or non-displaced, with the components loose. There's also another classification that is sometimes referred to, and it's the Sue classification. Type 1 involves a fracture that is proximal to the femoral component. Type 2 involves a fracture that originates at the femoral component and migrates proximally. And type 3 originates and ends distal to the anterior flange of the femoral component. When we talk about tibia fractures, usually people refer to the Felix classification. Type 1 is a tibia plateau fracture. Type 2 is a fracture adjacent to the stem. Type 3 is a fracture distal to the stem. And type 4 is a tubercle fracture. In the rare case that you have a patella fracture, it's basically, is the component stable, and is the extensor mechanism disrupted? Type 1 involves stable component, intact extensor mechanism. Type 2 involves a stable component with a disrupted extensor mechanism. And type 3 is split into type A and type B, and it depends on the amount of bone stock that's available. So we're going to tackle the femur side first. Supracondylar femur fractures in general are pretty rare, and they're not a common complication in all total knee replacements. But as the number of total knee procedures increases, the lifespan increases, more and more patients will be at risk. The most common risk factors are low energy falls, low bone density, older age, and rheumatologic illness. So there's also a theoretical risk of fracture with anterior notching, but it hasn't really been reflected in the literature. And this study reported that the femurs that were notched tended to fracture at the notch site, but the femurs that weren't notched just tended to fracture in the diaphysis. Among patients who experience this type of fracture in general, the pattern of injury can be quite variable, and a number of factors determine the optimal treatment for them. In 1967, Dr. Neer actually did a study and compared surgical and non-surgical treatment, and found that non-surgical treatment produced 90% satisfactory results and had fewer local complications, which is somewhat shocking considering that it involved casting, traction, and long periods of immobilization. Years later, the studies and the numbers had flipped to where most patients preferred operative intervention, likely due to the improvements made in the implants. We are going to come back to this study, but the general good result is that you have greater than 90 degrees of flexion at the knee after surgery. The fracture shortens less than 2 centimeters, and there is less than 5 degrees of varus valgus lean and less than 10 degrees of flexion and extension in the distal segment. This study out of India looked to characterize the fracture pattern and the subsequent treatments and found that the supracondylar type of fracture was the most common type of periprosthetic fracture when looking at the tibia side and the patella side. And the further incidence increased to 38% if you had a revision total knee. They used the Lewis and Rohrback classifications for distal femurs and found that 71% of their periprosthetic fractures occurred after a trivial fall, indicating that osteoporosis was a contributing factor. And while displacement was traditionally considered the major factor in determining surgical versus non-surgical evidence, sufficient evidence now supports that you should consider surgical management unless it is truly non-displaced or the patient is medically unfit for surgery. Out of the 26 cases that they saw, 18 fractures united after primary fixation, 2 fractures united after secondary fixation, and 6 fractures did not unite after multiple surgeries and had to undergo revision arthroplasty with the stem component to bypass the fracture site. One patient actually had to undergo a distal femoral replacement. The patient cohort that went immediately to revision total knee did not have an increased complication rate, and the recovery of those patients was found to be quicker. And if you see in this chart here, they were actually found to have better postoperative measures. The patients that had the best postoperative measures were the tibia fractures, but there were only 4 that they looked at in this group. So overall, patients were happier if they had their implant revised versus if they had ORIF in this study. Unfortunately, even in the postoperative period, complications can arise and be devastating. And this study sought to look at what complications could arise in the postoperative period and what was most common. That PJI was actually the most common cause of need for re-revision surgery after revision total joint. And we all know that it can be a long drawn out battle, especially if you have difficult to treat organisms. The rate of reoperation was 17.1% for patients treated with revision arthroplasty and 18.7% for patients that had revision and ORIF. And the most common indication included periprosthetic joint infection, but also refracture, loosening, or non-union of the fracture site. And of the 79 patients that they reported on in this study, 65 underwent ORIF and revision arthroplasty, and 49 of those underwent re-revision for PJI. The mean age of the re-revision group was also lower than that of the group that did not require re-revision, 68 versus 73. So ultimately what they found was that one revision was more likely to lead to a second revision, and that each subsequent one had a higher mortality and higher morbidity. I thought this was also a really interesting study to see whether surgeon training affected surgeon choice and whether they went to revision arthroplasty or ORIF. And the purpose of this study was just to examine if you had fellowship training in trauma, arthroplasty, or in both, and what your choice would be if you were presented with these 4 kind of Punnett square looking fractures here. You had comminuted fractures and you had simple fractures, and you had proximal and you had distal fractures in the distal femur. The surgeons were surveyed at participating sites as well as the alumni of the INSAL traveling fellowship, and they were asked years of practice, type of practice, and the number of arthroplasty procedures and number of periprosthetic fractures they fixed in a year. And as expected, the surgeons in the arthroplasty group by and far chose to revise the implant before they would choose fixation, and the surgeons that were trauma trained chose to fix the fracture, even the more comminuted distal fractures, as opposed to revise the implant. The surgeons that were dual trained in both trauma and arthroplasty sort of split the difference. They were more likely to fix the fractures than the arthroplasty surgeons, but they were less likely to revise to a DFR or another prosthesis than the arthroplasty surgeons. Higher volume surgeons were significantly more likely to recommend fixation over reconstructive arthroplasty. But the most important variable that they wanted to know before they chose how to fix the fracture or how to replace the implant was the location of the fracture, followed by predictability of the fracture pattern. So we're moving on to tibias now. This is kind of an example of how a tibia fracture would be treated with dual plating and with a period of immobilization. In this review article, they wanted to pull data from all existing papers to look at causes and treatments of tibia fractures under a total knee, because they are not nearly as common as their femoral counterparts. But they also have some unique treatment challenges because of the soft tissue envelope surrounding the tibia. The incidence is about 0.4 to 1.7%, depending on the study reference. Early postoperative tibia fractures have been linked to malposition or malrotation of the tibial component, which causes abnormal stress to the tibia. And late postoperative fractures are often a sequela of trauma or malalignment or knee instability. Assessment of implant stability is the most important factor when determining a treatment algorithm. This figure here shows the Felix classifications for the tibia fractures. And type 1 and type 2 both tend to cause the tibia to fall into varus and thus leading to later instability if they're not addressed. Bone quality is a major component of pre-op assessment. And if you can't tell if the implant is stable, you should definitely get a CT scan. Felix type 3 fractures that are sufficiently displaced should be managed with locking plates or, if possible, an IM nail. And you should also consider a revision total knee with a long stem component if you feel like you can't get adequate fixation. Megaprostheses are rarely indicated in this management because it's fairly hard to reestablish and reinsert the extensor mechanism. The study also recommended use of locking plates for fixation of the tibia plateau fractures around unicompartmental arthroplasties. Overall, there have been fewer advancements in treatment for tibia-sided fractures than for those on the femur side. A more recent paper also looked at outcomes after tibia fractures under a total knee. And in this retrospective study that looked at data from 2 level 1 centers, they found 53 patients out of the over 4,000 tibia fractures they looked at. Overall, there's about a 76.3% chance of fractures uniting by 6 months after the index procedure, leaving only 9 total non-unions. And when they were classified by Felix classification, the most non-unions happened with Felix type 2, which was in the metaphysis and around the stem. When classifying fractures by location, they found that the most common fracture was proximal and that the overall reoperation rate for all of these together was about 32%. Dual plating of the tibia on the medial and lateral surface did not correlate with improved union rates, but also did not show significant changes or significant difference in infection or reoperation between those that were single plated. Obviously, this one here that they showed as an example required reoperation and exchange to an IM nail after it failed plating of both the fibula and the tibia. Briefly, we'll hit on patellas and unis. So in the US, the number of unis done is far lower than the number of total knees done. And in contrast to the total knees, where the most common fractures in the femur side, periprosthetic fractures that happen in unis often happen in the tibia. And they can happen because of imbalance in load transfer, or bone resistance. Bone quality and quantity are of most importance when talking about possible reasons for failure and how to fix them. They're kind of classified into pure subsidence versus split or true fractures. Pure subsidence fractures are technically stable, and the decision-making must be based on the implant's final resting position and fixation. Split fractures are associated with metaphyseal bone loss, and so they need to be reconstructed for implant conservation and or bone stock reconstruction and for future conversion to a total knee. Conservative management is really only an option in the truly non-displaced fractures without any evidence of implant malposition or loosening, and long periods of immobilization can lead to malunion or subsidence once you start weight-bearing patients. A large review involving patella fractures was done out of Mayo, and this is actually where that classification system was born. And they found that the incidence was extremely low overall, about 0.05% in unresurfaced patellas and 0.2 to 20% in resurfaced patellas, depending on which study was referenced. They found a total of 36 patients in the largest study and about 5 to 10 in a bunch of other studies. The commonalities were that those that sustained fractures were male patients that had excessive resection or were excessive resection with or without patellar osteonecrosis, single peg implants, or metal back implants. And at the end of their follow-up, they found that the majority of type 1 fractures, which are these fractures here that have the implant intact and the extensor mechanism intact, were amenable to non-operative treatment. And whether they had fibers or bony union at the fracture site, the patients were doing quite well. Type 2 fractures created the most amount of complications relating to stiffness and wound breakdown, and type 3 fractures didn't necessarily require surgery unless the bone stock was extremely poor. This was their recommended treatment algorithm based on the patients that they looked at and what possible procedure they might warrant. So there were a number of operative pearls that I came across when I was doing research for this. So we'll kind of start with a little bit of history. So initially, surgical intervention was focused on fixed angle devices. And you can see in the picture here, these are the dynamic condylar screws and the blade plates. The blade plate was at 95 degrees and was used to maintain valgus alignment of the articular surface. Obviously, this femur doesn't have a total knee implant, but it was kind of hard to see what the blade plate was doing with those implants. It was technically demanding, and there were many local complications at the surgical site. So with the development of AO techniques and the importance of secondary bone healing, distal femur locking plates and intermedullary nailing was subsequently developed. So with a further understanding of bone healings and the soft tissue envelope, the less invasive stabilization system, LIS, by Synthes was designed for minimally invasive insertion that allowed for reduction of the articular surface using locking screws, and indirect reduction of the metaphyseal fractures. Most modern locking systems have an outrigger that allow you to percutaneously place more proximal screws. And the distal femur specific implants also help indirectly reduce fractures, but improper placement can lead to some specific malunions that later might require correction. Titanium plates have also been shown to have more symmetric callus formation at the fracture site compared to the stainless steel ones because of their modulus of elasticity that is closer to the bone. The use of longer plates with lower screw density more proximally has led to decreased rigidity at the fracture site and has solved some of the problems that initially happened with non-unions and locked plates. Studies have shown that having greater than 9 holes proximal to the fracture and filling 50% or fewer of those available holes decreases the non-union rate. Although even when micromotion is preserved, the lateral distal femur locking plate still generates asymmetric callus at the fracture site. And in patients with well-fixed total knee implants, a retrograde IM nail is a viable option and may provide some advantages and allow for early weight bearing as well as more symmetric callus formation. We really worry about callus formation because if the callus is very asymmetrical, you can lend yourself to varus or valgus deformity as a patient starts to weight bear. They do say that the fracture line must be proximal enough for good distal interlock fixation to control for axial and rotational forces, and the total knee must be amenable to accommodating an IM nail. Reducing the fracture in the coronal plane and the sagittal plane, as well as picking an appropriate start point, is important in these fractures. The newer nails from Synthes have a deeper sagittal bend distally to accommodate a more posterior start point within the box. It is recommended that the box be at least 1 millimeter larger than the diameter of the nail inserted, and most boxes are somewhere between 11 to 20 millimeters wide. And theoretically, you could widen the box with a metal cutting burr, but the metal debris could generate some third body wear and ultimately lead to revision of the total knee prosthesis. So this study from 2014 has this wonderful chart, which is too small for any of us to read. But this is the reference for if you have an implant and you don't know if the box is open or not, and you don't know if the box is going to be too posterior to accommodate a nail. Most implants on the market currently are open box and can accommodate a 10 millimeter nail with a 12 millimeter opening reamer. The new Synthes retrograde femoral nail advanced nail has a 11.2 specific opening reamer for narrow boxes for total knee implants, and they have both a 5-degree and a 10-degree distal bend for very posterior boxes, as Adrian reminds me every time I use one. They also have a series of washer and plate combos for the nail, so that if you have a fracture pattern where you just need a little bit of additional fixation, you can hook one of these onto the interlocks distally. And these come in a variety of offsets. In tibias, recent studies have looked at using IM nails to treat type 3 fractures, especially those in the shaft or distal shaft, instead of plating or dual plating. The original technique paper is attributed to Haller et al., and they described bending the distal tip of the nail with a tabletop bender to accommodate the turn near the stem. This case report out of India demonstrates that they did not need to bend the distal nail. They just had to measure and choose their patients correctly. And by 6 months, all of their patients were at a pre-injury level of activity. So what they did was measure the length of the stem and the distance from the stem to the tibial tubercle. They also measured the distance of the Herzog bend of the nail and the distance from it to where it may lie next to the tubercle. This is a synthes nail that they use showing here. And the actual diameter of the corresponding broad part of this nail is 11 millimeters. So to accommodate that as well as the bend, they recommended a safe distance of 4 millimeters on either side of the nail in the ADP direction to be safely out of the cement mantle. Keeping this in mind, this is a synthes nail that we use, and it's a matter of calculating the hypotenuse to see if the bend will get past the stem and if there's enough bone in the tubercle to accommodate the 12 millimeter opening awl. And theoretically, it could accommodate a stem that is less than 75 millimeters. If you're using the nail that they recommended in the study, it's a 65 millimeter bend. So in terms of technique, they use the infrapatellar approach through the previously made midline incision, and then use the opening awl and a hand reamer to get past the implant, and then a power reamer distally, and then locked the nail proximally and distally per protocol. I took a brief look at what implants we tended to use here and measured the distance between the stem and the anterior of the tibial implant to give a rough guide of if we were even looking at possibly putting a nail down with these implants. And as you can see here in a paper by Sechrist et al., there are different stem lengths for these tibial implants. And this is a good reference guide if you're trying to figure out if your patient's implant will even accommodate an IM nail. And I imagine that as a number of total knees increases and the population increases as well as patients living longer, that we will see a rise in improving technology for tibia fixation. So these are the things that you need to consider at the end of all of this. Is your implant stable? That is the most important question you answer first. Second question is, what is the host bone like? Is there quality bone? Is there abundant quantity of bone? And then you can discuss whether you do ORIF versus revision. What are their comorbidities? What is their function level before? And third, what implant will help you immobilize the fracture, but mobilize the patient sooner? And number four, most importantly, what happens if your fixation fails? So with that, I'd like to thank Dr. Sechrist, who lent me his brain and his dog for this week. It might be my final grand rounds, maybe. I'd like to thank Dr. Beaver, Dr. Shu, Scott Bivens, and Chris Petrie.
Thank you, Catherine. Welcome input from anybody here. I think that, the beginning you sort of talked about the trauma surgeon versus the arthroplasty surgeon. It is always a tough discussion. We've looked into doing a couple of prospective studies, but getting people to sort of buy into randomizing is pretty hard, because I think everybody has their biases built in, and it's always hard. I think that, to me, having done, I don't know, a good number of revisions of failed ORIFs to distal femur implants, I can tell you from the person, their reaction to being able to weight bear immediately after surgery is pretty interesting. It's like, why did I sit in a wheelchair for 3 months after my first operation? Because many of them are older, they can't comply with a walker and touchdown weight bearing, and so I don't really know how to answer that, because many of them, they were very appropriate choices. I wouldn't have said that they shouldn't have had that, but just that one piece of being able to weight bear immediately definitely biases me strongly towards the revision arthroplasty side, especially distal femurs. So I know we have a number of folks on the line. Any comments from anyone? I was also very interested in the tibial nail below the knee. I hadn't ever done that before.
I'm on a mission to map out our implants and come up with some sort of guide so that before you even address all of this, you can see if you can put a nail down.
Hey, Catherine, this is John Masanis. That was a great, very comprehensive talk. One question that I have just in that last one, or I should comment before the question, but comment, as you mentioned, having the trauma experience, I think, is a real big advantage when you're trying to deal with these for the arthroplasty group. And if you're in a location where you don't have one person that shares both arthroplasty and trauma experience, then I think it's a great idea to have a combined approach on these, if not intra-op, at least pre-operatively, to have a little bit of a group decision making on what would be appropriate fixation or revision. And then the last question that I'd bring up, you showed an example of the tibial nail. Obviously that tibial component was actually in a little reverse slope. It made it a bit easy, right? So it's not specific necessarily to just the implant. It's, how far down, what was the tibial resection at the time of the primary or the revision, and what's the, slope of that tibia to determine whether or not you can, treat it with a nail. To my knowledge, we haven't seen any of the nail constructs fracture, proximally by creating another defect, but I'll be interested to see if they do better than the plating constructs, because certainly we've struggled with the single plate, and the double plates obviously have their downfalls as well.
I don't know if Dr. Shu is on still, but I know he's done a handful of them, probably 5 or 6. And he said that his personal experience is that they've liked it a lot and they've healed pretty well. He does limit their weight bearing in the very beginning. And in the paper, they did do partial weight bearing for about 6 weeks, but he did say that if he does plate the tibia, he has them walk with a fracture brace, and he really limits their weight bearing until he sees fracture callus.
Hey, this is Larry Kempton. Just a couple other thoughts on what's been said. The idea of weight bearing immediately post-op, that a lot of times with both nails and plates, probably more often with nails, even with single implant fixation of distal femur fractures, a lot of us are letting those patients weight bear right away. And then even if you aren't comfortable weight bearing right away on that, there are 2 small to medium sized case series of patients that have been published showing 100% union rate in one, and I think high 90% union rate with no complications associated with weight bearing in nail plate constructs. So even if weight bearing is your primary concern, you can always go to a nail plate construct to fix these, and there's pretty good evidence for that. Cost effectiveness studies have also shown, mainly because of the cost of the distal femur replacement and also the cost of revision surgery, that fixation is a higher cost effectiveness as well, mainly just because cost is the driver. The other thing I'd say is that with nailing periprosthetic distal femur fractures, you can't necessarily always trust the papers that say what implants do have a closed versus open box. A lot of times you can see a path through the femoral component that you can put a nail through, even if it's a system with a box and you get a notch view. And even if you're not sure, you can always start the case by making a lateral peripatellar arthrotomy like you would if you were going to plate, and then look to see if there is like a plastic plug or something in the way that you can get a nail through. Even with a poly post, you can kind of subluxate the knee and get a nail past that in many cases.
Thanks, Will. I'm gonna say we had a lot of two great talks this morning, lots of discussion. I think each of these discussions could have been about 20 minutes in and of themselves, but thanks to Dr. Lee and Dr. Haisong for some excellent talks this morning. I know we all learned a lot, and we will look forward to seeing everyone next week. Thank you all.
Thank you.